Welcome, everyone. Ever stop to think about the human face? I mean, it's really an incredible structure, so intricate, so many bones working together, but somehow, usually pretty resilient. Still, something like a car accident seems straightforward, maybe, but it can cause some surprisingly complex damage hiding just under the surface. So today, we're doing a deep dive into maxillary fractures. That's the upper jawbone, essentially. We're looking at a detailed medical text about how these are managed. Our goal isn't just to list facts, but to really unpack how medicine has figured out ways to fix these really challenging injuries over time. Think of this as your shortcut to understanding a key bit of facial trauma. We'll cover everything from, well, ancient treatments right up to the latest surgical techniques. Hopefully you'll have some aha moments about how your own face is built. Okay, let's get into this fascinating look at maxillary fractures and the journey of medical understanding. So maybe let's start with the basics. The why and who, what usually causes these upper jaw fractures, and who tends to get them most often.
Right. Well, the data is pretty clear. Motor vehicle accidents and motorcycle accidents are definitely the most frequent causes.
Okay.
And a really crucial point is that these fractures, they rarely happen in isolation.
Ah, right. So it's not just the maxilla.
Exactly.
Yeah.
You're often looking at a patient who also has other facial fractures, maybe significant cuts, orthopedic injuries elsewhere in the body, even neurological issues.
Yeah.
It really shows how interconnected everything is during major trauma.
That makes sense. A big impact has widespread effects. What about the demographics? Is there a typical patient profile?
There is, yeah. It's most common in young men,
Yeah.
typically between 16 and 40 years old.
Young men, okay.
And the peak incidence, the highest rate, is actually between 21 and 25.
Mm.
Interestingly, though, while young men get them more often, the severity of the fractures tends to increase as patients get older.
Oh, that's interesting. So older patients might have worse breaks.
Potentially, yes.
Mm.
And knowing these patterns, young men-associated injuries, it's incredibly useful.
Ah.
Well, it directly informs how emergency responders approach the scene, what they look for in the trauma bay.
Mm-hmm.
It also shapes public health efforts, prevention campaigns. It connects the dots between the injury stats and actual medical practice.
That's a really clear link. Now, something that blew me away, and I think you'll find this fascinating too, is the history here. We associate certain names with these fractures now, but people were describing and even treating them thousands of years ago.
Incredible, isn't it?
Yeah. The Smith Papyrus, which dates back to around 2500 BC,
What?
it contains the first known clinical description of a maxillary fracture. Imagine that. Doctors millennia ago trying to figure this out. There are even mentions of, therapeutic fracturing of the maxilla in other old texts.
Really gives you perspective.
Totally. Then, jumping forward quite a bit to the 19th century, we start seeing more detailed work. Charles Reich, in 1822, wrote the first proper treatise on these fractures.
Mm-hmm.
And then Carl van Graef, just a year later, described using a head frame that sounds, honestly, almost as complex as some modern devices.
So the basic ideas of stabilization were there early on.
Seems like it. But the name everyone still links to these fractures today is René Lefort. His work in 1901 was the real turning point.
Absolutely. Lefort's classification is foundational.
And his method was something else. He didn't just observe patients. He did this incredibly detailed study using, get this, 32 cadavers.
Right. The cadaver studies were key.
Yeah, he'd subject the heads to different types of trauma and then meticulously remove the soft tissue to see exactly where the bones broke. Almost like forensic science.
A very direct way to understand the fracture patterns.
And his big discovery was noticing these predictable lines of weakness in the face. He saw that often, if the face broke, the skull itself didn't, suggesting the force traveled along specific paths.
Fascinating observation.
He identified three main patterns, these three weak lines, which became the basis for his classification system. And we still use Lefort the third today, over 120 years later.
It's remarkable longevity for a classification system.
It really is. So his system considers things like the force direction, bone thickness, basically mapping how the mid-face tends to break. Should we quickly run through the three levels?
Yeah, that's a good idea. They build on each other.
Okay, so Lefort the first, that's the lowest one. It's a horizontal fracture, basically separating the tooth-bearing part of the upper jaw and the palate from the rest of the face, sometimes called the floating palate.
Right, detaches the tooth arch.
Then Lefort 2, this one's often called pyramidal. It goes higher, involves the nasal bones, runs down through the eye sockets, and detaches a sort of pyramid-shaped section of the midface.
Involves the nose and parts of the orbit, yeah.
And Lefort 3rd, that's craniofacial disjunction, the big one. This is where the entire face, cheekbones, nose, maxilla, everything separates from the base of the skull.
A complete separation. Massive trauma.
Exactly. The fracture line runs right across the top of the face, through the orbits, deep into the skull base. And important point, you can have combinations, right? Like a fort first on one side and a tine on the other.
Oh, absolutely. Trauma isn't usually symmetrical. You can see combinations or variations of these patterns all the time.
It's just incredible how his careful, almost forensic work laid this groundwork that's still so relevant.
It truly is. It speaks volumes about the power of really detailed anatomical observation. Those lines of weakness he found are still what surgeons visualize when planning repairs.
Which brings us perfectly to the anatomy itself. Why does the maxilla break along these lines? What makes it vulnerable but also strong in some ways?
Well, the maxilla isn't just one bone. It's actually two, fused down the middle, forming this sort of pyramid shape in the center of your face. And it connects to a lot of other bones, the cheekbones, nasal bones, base of the skull.
It's like the central hub.
Pretty much, yeah. Now, a key feature that makes it inherently a bit weak is the maxillary sinus.
The air pocket inside.
Exactly. It's a big cavity, roughly 34 by 33 by 25 millimeters in adults, full of air. It develops fully around age 14 or 15. This hollowness just makes the bone structure less dense, more prone to fracture.
Okay, so the sinus is a weak point. But it's not totally fragile, right? You mentioned strength, too.
Correct. It has these reinforcing pillars, we call them buttresses. There are four main ones. One near the nose, lateral piriform, one connecting to the cheekbone, zygomatic, one along the palate, greater palatine, and the floor of the nose itself acts like one too.
Like beams holding up a structure.
That's a great analogy. They help absorb and distribute forces, but the location is tricky.
What do you mean?
It's right next to some really critical and delicate structures.
Such as?
Well, just above and behind it, you have the ethmoid bone and the cribriform plate at the base of the skull. The ethmoid is very thin, very pneumatized, lots of air cells.
Okay.
If a maxillary fracture pushes the midface backwards or upwards forcefully, it can easily break that thin cribriform plate. And right above that is the dura mater, the brain's protective lining.
Ah, so a tear there could mean.
A cerebrospinal fluid leak. CSF leak, yeah, that's a major concern.
Wow. Okay, what else is nearby?
The infraorbital nerve. It runs right through the floor of the eye socket, which is part of the maxilla, and comes out on the cheek to give feeling. Very easy to injure in these fractures.
Leading to numbness.
Numbness in the cheek, upper lip, side of the nose, yeah. And then deeper behind the maxilla, you have the internal maxillary artery.
Artery. So a bleeding risk.
Potentially massive bleeding risk. If that artery gets torn or ruptured, it can cause devastating hemorrhage. It's tucked in there, but high-energy fractures can definitely reach it.
So we've got this bone that's partly hollow, reinforced by beams, but surrounded by nerves, arteries, and a gateway to the brain cavity. It's complex.
Extremely complex, which is why diagnosis needs to be thorough.
Right. So how do doctors figure out if the maxilla is broken and how badly?
First things first, in any major trauma, it's always ATLS protocols, advanced trauma life support. Airway, breathing, circulation, stabilize the patient first.
Always the priority.
Then, during the secondary survey, comes the detailed maxillofacial exam. There's actually a great quote from a Dr. Blair back in 1914.
Oh.
He wrote, "In all cases of injury of the face, the dental arches and the palate should be inspected, and the facial bones outlined digitally." Even then, they knew you had to look inside the mouth and feel the bones.
Digital palpation. Still fundamental. What are the visual clues?
You look for things like bruising around the eyes, raccoon eyes is the classic sign, general facial swelling, obviously, a nosebleed or epistaxis, and you always check that bloody fluid for any clear CSF.
Checking for that brain fluid leak.
Exactly. Inside the mouth, you look for broken teeth, bruising on the gums or palate, cuts in the mucosa, any steps or gaps between the upper teeth, and crucially, malocclusion. Does the bite fit together properly?
Does the bite feel off?
Precisely. Then comes the hands-on part. Carefully feeling the whole facial skeleton, checking for movement where there shouldn't be any. The most obvious sign of a maxillary fracture is what they call a mobile maxilla.
How do you test that?
You gently grasp the front part of the upper jaw, between thumb and forefinger, and try to move it while stabilizing the bridge of the nose with your other hand. If the whole segment moves, well, that's pretty diagnostic.
You can literally feel the break.
You can, but clinical exam alone isn't enough anymore.
Imaging, I assume.
Definitely.
Yeah.
Back in the day, they relied on specific x-rays like the Waters view, still used sometimes in rural places. But the absolute standard now is CT scans, computed tomography.
Much more detail.
Oh, vastly more. Axial and coronal views give you these incredible detailed cross-sections. They're essential for seeing everything clearly, especially subtle fractures of the orbital floor. The coronal view is best for that and for planning the surgery meticulously.
What about 3D CTs?
Those are fantastic, especially for really severe trauma where everything is displaced. They give you this amazing overall picture, helps you visualize the whole reconstruction.
So it's a combination of careful hands-on exam and high-tech imaging.
Exactly. It really highlights this blend, doesn't it? The art of clinical assessment, honed over centuries, combined with the science of modern imaging. You really need both for an accurate diagnosis and the best treatment plan.
Makes sense. Okay, so diagnosis is done. What about treatment? How has that changed?
Well, like diagnosis, the immediate priorities haven't changed. Secure the airway, stop the bleeding,
ABCs again?
always. With LaFour fractures, bleeding often comes from a fractured nasal septum. That can usually be controlled with nasal packing gauze, special sponges like Maricel, that sort of thing.
But what about that internal maxillary artery you mentioned? If that's bleeding?
That's the serious scenario.
Yeah.
If nasal packing doesn't work and the bleeding is severe, that strongly suggests a major vessel injury, likely the internal maxillary or one of its branches. That's an emergency requiring an interventional radiologist.
They go in and block the vessel.
Right. Angiography to find the bleeder, then embolization to block it off. It's rare for facial fractures alone to cause exsanguinating hemorrhage, but it can happen, and it's almost always that artery.
Scary stuff. Okay, assuming bleeding is controlled, what did historical treatments look like? You mentioned head frames.
Yeah, pretty cumbersome stuff. Back in the late 1800s, Gerritsen talked about using bandages and dressings wrapped around the head to basically push the lower jaw up against the upper jaw, holding the fracture in place. Materials like plaster, wood, gutta percha,
Sounds uncomfortable.
I imagine. Then by the early 1900s, people like Blair realized that wasn't enough. They started advocating for maxillary splints. Dr. Marshall described this really elaborate setup, taking impressions of the teeth, making a hard rubber splint attached to wires, connected by elastic straps to a reinforced cap worn on the head.
Wow, like external scaffolding for the face.
Pretty much. The whole goal was, as Marshall put it, to furnish a sure guide to the normal position of the superior macullae, trying to get things lined up.
So how do we do it today? I'm guessing no more leather head caps.
Thankfully, no. The standard of care now is rigid internal fixation.
Plates and screws.
Exactly. Tiny titanium plates and screws. Different sizes depending on the location, maybe 1.5 millimeter for general maxillary areas, smaller 1.1 or 1.3 for around the eye socket or nose, and slightly larger 1.7 or 2.0 if the bone is really shattered or comminuted.
Titanium, huh? Strong and biocompatible.
Very. The typical sequence starts with putting on arch bars if the patient has teeth. These are metal bars wired to the teeth to help align things. Any unsalvageable teeth usually come out then.
Okay.
Now, if the mandible, the lower jaw, is also broken, which is common, surgeons often fix that first.
Why the lower jaw first?
Because an intact, stable mandible gives you a reliable reference point for setting the position, especially the forward projection, of the fractured maxilla. You then use intermaxillary fixation, temporarily wiring or banding the upper and lower jaws together in the correct bite to hold that position.
Makes sense. Use the good part to fix the broken part.
Precisely. Then you use those titanium plates and screws to rigidly fix the maxilla to the next stable bone higher up. For Olafort I, that might be the buttresses near the nose and cheekbones. For higher fractures, you might plate to the nasal bones, the orbital rims, or the zygomatico-frontal suture way up by the temple.
So you're basically rebuilding the connections.
Yeah, you are. And modern CT scans and these rigid fixation techniques mean surgeons can often treat multiple fractures almost independently rather than being strictly limited by the classic LaFour levels.
What if the fracture is really stuck, impacted?
Good question. Sometimes you need special instruments, like row disimpaction forceps. One end goes in the nose, the other hooks onto the palate, and you use them to gently pull the maxilla down and forward, dislodging it.
Forceful but controlled.
Exactly. And sometimes, for really stubborn greenstick fractures or severe impactions, you might actually need to perform a controlled osteotomy, making a deliberate cut with a small chisel to free the impacted segment. Blair even mentioned this back in 1914.
History repeating itself, sort of.
In a way, yeah, it allows you to mobilize the bone properly before fixing it.
What about gaps? If bone is missing or crushed?
That's where bone grafting comes in, or increasingly, titanium mesh, especially for the crushed wall of the maxillary sinus.
Why mesh?
Titanium mesh is great. It's strong but malleable. You can shape it easily. It holds the space, resists pressure from the soft tissues, and it actually osseointegrates bone grows into it. It provides a scaffold that allows the natural sinus lining to regrow over it.
That's pretty cool. What about patients with few or no teeth? Splints.
Yes, surgical splints are still used. Occlusal wafers, which fit between the teeth, can help in complex cases. For patients with no teeth, edentulous patients, we use something called a gunning splint. It's like a denture base plate, sometimes made from their existing denture, with arch bars or hooks added. It's then secured directly to the facial bone's palate, piriform rims with screws or wires.
So lots of tools in the toolbox.
Definitely. And you can see the progression clearly, right? From external strapping and headgear to internal, precise, rigid fixation based on detailed anatomical understanding and biomechanics. It's all aimed at restoring not just the form, but the critical functions: breathing, chewing, speaking.
That evolution is really striking. And it highlights, like you said earlier, that treatment needs to be tailored. It's not one size fits all.
Not at all. Consider really high-force injuries, serious gunshot wounds, blast injuries, high-speed crashes.
Devastating injuries.
Absolutely. The priority there is saving as much tissue as possible, controlling contamination with antibiotics and thorough cleaning, managing bleeding aggressively, often needing angiography. Then rigid fixation of what remains, followed by later reconstruction for missing bone, sometimes even requiring moving tissue with its own blood supply, free flaps if soft tissue is also gone.
Complex reconstructions.
Very. Now think about geriatric patients. Their bone is different, less blood supply, more air in the sinuses, maybe less dense bone overall. Healing can be slower.
And other health issues.
Exactly. They often have other medical problems that make long surgeries riskier. So for an older patient with a minimally displaced fracture, the surgeon might decide that making a new, well-fitting denture is actually a better, safer option than surgery. It's about judgment.
Tailoring the risk-benefit. What about kids?
Pediatric maxillary fractures are actually quite rare. Kids' faces are built differently, less developed sinuses, more resilient bone in some ways. They're about 5 times less likely to have facial fractures than teenagers.
That's fortunate.
It is. When they do happen, mobile, displaced fractures still need fixation. But the huge concern is the developing permanent teeth.
Ah, the tooth buds under the gums.
Precisely. You absolutely have to avoid damaging them when placing screws or plates. That's why resorbable plating systems are strongly preferred in children.
Plates that dissolve over time.
Yes. Made of materials that the body gradually absorbs. This avoids potential long-term problems you can see with metal plates in growing children, like plates shifting, becoming exposed, or even restricting growth. There's a lot of evidence from craniofacial surgery supporting their use in kids.
So different age groups, different injury types, all need specific approaches.
Exactly right.
But even with the best planning and skill, things can go wrong. Given how crowded that area is, what are the main complications surgeons worry about?
That's a critical question. And the risks span from immediate, life-threatening issues right through to subtle long-term problems. Airway obstruction is a big one, right around the time of surgery or just after.
Why would that happen?
Could be sedation-reducing consciousness, a blood clot in the septum, swelling from the surgery or packing, or even the wires holding the jaws shut. It might require urgent intervention, even re-intubation. And longer term, if a nasal septal fracture isn't fixed properly or if sinus drainage pathways are blocked by fracture lines, you can get chronic breathing problems or sinusitis.
Okay, airway is number one. What else?
Bleeding again, post-operative hemorrhage. Maybe a small vessel wasn't tied off, or maybe the bone reduction wasn't quite stable. Sometimes an aneurysm can form on an injured artery. It might mean going back to surgery to drain a hematoma, using bone wax, or even needing that emergency angiography again.
In the eyes, you mentioned the proximity.
Vision complications are definitely a major concern, especially with Lefort 2 and 3 fractures that involve the orbits. Blindness is rare, thankfully, but it can happen.
Oh.
Usually due to increased pressure inside the orbit from bleeding retrobulbar hemorrhage or direct damage or impingement on the optic nerve. Even if vision is okay initially, if an orbital floor fracture isn't diagnosed or treated properly, the patient can end up with a sunken eye, an ophthalmos, or persistent double vision, diplopia.
Those sound like life-altering complications.
They can be. Then there are issues with the fixation itself and healing. Hardware can be misplaced, leading to a bad bite that needs correcting surgically. Plates can sometimes be felt under the skin, get infected, or even extrude. Very rarely, the bone just doesn't heal non-union due to poor blood supply, infection, movement, or other factors.
Infections seem like a risk with any facial injury.
They are. Contamination from cuts, foreign bodies, dental problems. Infections can pop up even years later around old plates.
And finally, what about malunion? Healing in the wrong spot.
Right. If the bones heal incorrectly, it can cause specific problems depending on where the malunion is. For instance, it could block the nasolacrimal duct, causing constant tearing or epiphora. Or bone fragments could press on that infraorbital nerve we talked about, causing persistent numbness.
So it's not just about making the bones stick together.
Not at all. It's about putting them back in exactly the right place, respecting all the surrounding delicate structures to restore function and avoid these long-term problems. The precision required is immense because the consequences of even small errors can be significant for the patient's quality of life.
Wow. What an incredible journey we've covered. From descriptions on ancient papyrus scrolls to surgeons today using advanced imaging and titanium mesh and resorbable plates. It's really something.
The progress is remarkable.
And Laforte's work, done over a century ago with cadavers, still providing that fundamental map. It's just fascinating how foundational insights persist even as technology leaps forward.
It really underscores the importance of understanding the basics, the anatomy, and the patterns.
I think this deep dive really hammers home how complex even seemingly common injuries can be, and the sheer depth of knowledge and skill needed to manage them. The face is such a marvel, both in how it's built and how medicine has learned to put it back together.
Agreed. It's a testament to medical ingenuity.
So, as we wrap up, here's something to think about. We know the maxilla is vital for looks, but also for basic functions, breathing, speaking, eating. Looking ahead, how might future tech, maybe personalized medicine, 3D bioprinting, or regenerative therapies, change things even further? Could we move beyond just fixing fractures to truly rebuilding them with even greater precision, maybe using patient-specific living tissue to guarantee everyone gets back to their pre-injury state, both form and function?
That's the exciting frontier, isn't it? True regeneration rather than just repair. A fascinating thought to end on.